Providence. I'm up on B5. And as some of you might know, B5 used to be our COVID ward here, our COVID recovery ward. And so I was the first MRP of that ward, and over the course of the last year, I had a lot of exposure to COVID and in terms of managing COVID patients. And of course, once the vaccines became like a thing, I immediately was extremely interested and tried to learn as much as I can about it. So I'm sure everyone is feeling that way, especially now with the vaccine rollout happening here in our province. And I know that I've been fielding a lot of questions about it, and I'm sure many of you have had questions and many of you have been fielding questions as well. So we felt that this information session would be very timely. And we are lucky enough to have Dr. Malika Sharma here with us today. I'm just going to introduce Dr. Sharma. So she has completed her MD at McMaster University, after which she completed an internal medicine and adult infectious disease postgraduate at the University of Toronto. She also went on to complete a master's in education for the Ontario Institute for Studies in Education at U of T as well. Currently, Dr. Sharma is an HIV and infectious disease physician and clinician teacher at St. Michael's Hospital, where she is also education lead for the Division of Infectious Diseases. Clinically, Dr. Sharma focuses on caring for people in communities who are marginalized and oppressed by healthcare systems, including, that's a little bit of my dictation, forget that I said comma, including those who use substances and people living with HIV. Her teaching and scholarly interests center on anti-racist and feminist practices within medical education, harm reduction, and the structural determinants of health. We've got all your questions and we've collated them into one document. And so we will go over all the questions during Dr. Sharma's presentation. And if anything remains afterwards, we'll address those. If anyone has any questions, I invite you to put your question into the chat box and I will keep track of them. And once we are all done hearing Dr. Sharma speak, we'll then go over each question or batch the questions if there are multiple of the same one, and then she'll be able to address everything. And so hopefully we'll all leave here today with the same understanding of how these vaccines are going to save us all. Dr. Sharma?
Thank you so much, Teela. And not to worry, that's like when I sign birthday cards with my CPSO number. So it's the same phenomenon. Thank you so much for having me. And it's sort of exciting. I actually see Dr. Sharon Marr, who interviewed me for medical school or for residency in the group. So that's kind of neat. I'm going to share my screen. I have slides, but it's not so much for us to kind of, go through a formal presentation as it is just to guide and give us some structure around what we're going to discuss today. I'm just going to keep an eye on my time as well. So I think as you've kind of highlighted, a lot of us are fielding a variety of questions around COVID vaccination. And I think this is in part driven by, I don't really like using the term vaccine hesitancy so much as it is, I think, vaccine deliberation. People trying to understand, what are the safety profiles of these vaccines? Are they efficacious? Getting some of their concerns addressed, getting some of their confusion addressed, because I think more so than at any time before that, at least I can remember, and certainly that even some of my older colleagues can remember, we're having a lot of science by press release. And so we're not necessarily seeing that same pace of scholarly or medical information coming out where we have the chance to actually truly understand the data, review it in Journal Club. It's all kind of coming out fast paced and in real time. I think making it quite hard to know kind of what's real and what's conjecture. And then I think there's kind of ethical and reasons of altruism as well that people have around thinking through vaccines, because, vaccines they're fascinating in the sense that, it's very much a deeply personal and embodied phenomenon, right? So you are getting an injection into your arm. However, it is also fundamentally a communal or a population level act, right? Because the only ways that vaccines work really are at the broader community or population level through herd immunity. And so I think people, and particularly in an environment like ours right now, where there's this feeling of scarcity and vaccine limitations at the population level, I think people have a lot of concerns around some of those things as well. So hopefully we'll talk a lot about that. The one other thing I'll sort of mention is that vaccine deliberation affects different people differently and different communities differently in terms of access to information, access to language concordant information, access to culturally appropriate information. And I think a number of efforts have been made to try to address this, particularly through grassroots-led and community-led organizations. And so there's some really great information out there, for example, from South Asian community groups, from Afro-Caribbean and Black community groups in Toronto. And I encourage you to look into those if those are of interest to you. And I'm happy to provide some links as well around that. But I think that again, that's kind of why I focus on this notion of vaccine deliberation rather than hesitancy, because I think actually a lot of the deliberation comes from not necessarily having access to the kinds of information people need to make these decisions. Hopefully we can address a little bit of that today together. So in terms of thinking about what vaccines are available in Canada right now, we essentially have these four. So the Pfizer, Moderna, both of which are mRNA vaccines. I'll talk more about what that means in a bit. And then there's the AstraZeneca vaccine, which has been in the news a lot, and this more recent Janssen or Johnson & Johnson vaccine, which both use non-replicating viral vectors. And AstraZeneca, as you know, has also been in the news a lot, and we'll talk more about that as well. In terms of authorized groups, you can see that Pfizer is greater than 16, Moderna is greater than 18, the Johnson & Johnson is greater than 18. AstraZeneca has not been recommended for individuals greater than 65 years of age in terms of its efficacy. And as you know, it's been a bit of a shifting target in terms of who's kind of been allowed to get it in Toronto, where for a while it was not recommended for people less than 55 because of concerns around blood clots that form. We'll talk more about that. And now has been recommended for people 40 years or older. All of them except for the Janssen or the Johnson & Johnson are 2-dose. The J&J one is 1 dose. The schedule for all of these is, you know, somewhere in that kind of 3 to 4 week range, except for obviously the one that's just a 1 dose. However, all of them have been extended up to 4 months in a variety of settings, including our own, where right now, unless there's very specific indications for a shortened interval, so for example, if you're a transplant patient, you get the regular 3-week interval, for example, if you have a Pfizer, or the 4-week if you have Moderna. Other than that, people have been had their second dose essentially deferred to the 4-month mark. I'm going to talk about that as well in a separate slide. So the one other kind of piece that I think at the kind of broader delivery level is important is that the Pfizer vaccine requires this ultra cold freezer that's -80 to -60 degrees, whereas Moderna requires a standard freezer, and then the other two just require standard refrigeration. So how do these vaccines work? Let's see if I can do this. What I'm actually going to do is I'm going to stop my share for a second so that I can just share my whole screen with you, because I feel like that might be the best way to make sure you can actually see it. So you can see that I have way too many tabs open. This is a TikTok video that I loved because I think, A, we need a little bit of humor, but I actually really liked how he explained this.
You need to make this. What is it? It's a part of a virus. A virus? Just a part of it, not the actual virus. They're called COVID-19. They have 4 cans and they're coming. 4 cans? Please. What is this? This messenger told me to make them. I've never seen these before. I'll make some new antibodies to get rid of them. Seize the forks. Nice body. Gonna make this place my new home. 4 cans. Seize them. Ah! You need to make
Now I have to stop it.
It's a part of a virus.
Otherwise, it's just going to loop forever. All right. The reason I like that, video, despite the fact, not just because it's funny, is that it actually highlights to me a couple of important things. So one is that mRNA vaccines in particular, the mRNA, it's not integrating into the host DNA, it's not integrating into our genome in any way, which is sometimes a concern that people have, is like, is this going to affect my DNA in some way? So the answer to that is no, because it's not stable enough. It's A, that's not really how it works, but B, it's not stable enough. You could see it sort of died right away. So it doesn't last very long in the body. It essentially just it's a messenger RNA. It gives the message, make these proteins, and then once it's done that, it's essentially degraded. The forcans, by the way, are the spike proteins, which I quite liked. The question of, do these vaccines work? So I don't want you to focus so much on the graph part of it, because it's sort of plotting how effective is the vaccine by how often did someone have a systemic vaccine reaction. It's more to sort of show you the efficacy of the vaccine itself. So you can see that the 1 dose Janssen is about 70% effective. The Moderna, the 2 doses are about 94% and 95% for the Pfizer, with the AstraZeneca being about 60% effective overall. And I have another video that I wanted to show you. And if the videos aren't working, you can just send me let me know, and we can defer that. But I have found them helpful in sort of understanding the idea of vaccine efficacy. And they say it in a way that's sort of just way more clear than I could say. So I'm going to share this video, and let me know if there's any issues with seeing it. You're going to see this advertisement first, I think.
You order with Skip, delivery's on. You'll get all the free delivery from all restaurants. Order from the...
This is the new 1-dose COVID-19 vaccine from Johnson & Johnson. In early March, more than 6,000 doses were supposed to be shipped to the city of Detroit, Michigan. But the mayor said, no thanks.
Moderna and Pfizer are the best. And I am going to do everything I can to make sure the residents of the city of Detroit get the best.
He was referring to these numbers, the vaccine's efficacy rates. The vaccines from Pfizer, BioNTech, and Moderna have super high efficacy rates, 95 and 94%. But Johnson & Johnson, just 66. And if you only look at these numbers, it's natural to think that these vaccines are worse than these. But that assumption is wrong. These numbers are arguably not even the most important measure of how effective these vaccines are. To understand what is, you first have to understand what vaccines are even supposed to do. A vaccine's efficacy rate is calculated in large clinical trials, when the vaccine is tested on tens of thousands of people. Those people are broken into 2 groups. Half get the vaccine and half get a placebo. Then they're sent out to live their lives while scientists monitor whether or not they get COVID-19 over several months. In the trial for Pfizer-BioNTech, for example, there were 43,000 participants. In the end, 170 people were infected with COVID-19. And how those people fall into each of these groups determines a vaccine's efficacy. If the 170 were evenly split, that would mean you're just as likely to get sick with the vaccine as without it, so it would have a 0% efficacy. If all 170 were in the placebo group and 0 people who got the vaccine were sick, the vaccine would have an efficacy of 100%. With this particular trial, there were 162 in the placebo group and just 8 in the vaccine group. It means those who had the vaccine were 95% less likely to get COVID-19. The vaccine had a 95% efficacy. Now, this doesn't mean if 100 people are vaccinated, 5 of them will get sick. Instead, that 95% number applies to the individual. So each vaccinated person is 95% less likely than a person without a vaccine to get sick each time they're exposed to COVID-19. And every vaccine's efficacy rate is calculated in the same way. But each vaccine's trial might be done in very different circumstances.
So one of the biggest considerations here when we look at these numbers is the timing in which these clinical trials were performed.
This is the number of daily COVID-19 cases in the US since the pandemic began. The Moderna trial was done completely in the US, here in the summer. The Pfizer-BioNTech trial was primarily based in the US too, and at the same time. Johnson & Johnson, however, held their US trial at this time, when there were more opportunities for participants to be exposed to infections. And most of their trial took place in other countries, primarily South Africa and Brazil. And in these other countries, not only were case rates high, but the virus itself was different. The trials took place as variants of COVID-19 emerged and became dominant infections in these countries, variants that are more likely to get participants sick. In South Africa, most of the Johnson & Johnson trial were that of the variant, not the original strain that was in the US over the summer. And despite that, it still significantly reduced infections.
If you're trying to make one-to-one head-to-head comparisons between vaccines, they need to have been studied in the same trial with the same inclusion criteria in the same parts of the world at the same time.
If we were to take Pfizer and Moderna's vaccine and redo their clinical trial at the same time that we did J&J's clinical trial, we might see quite different efficacy numbers for those.
These efficacy numbers really just tell you what happened in each vaccine's trial, not exactly what will happen in the real world. But many experts argue this isn't even the best number to judge a vaccine by anyway, because preventing any infection at all is not always the point of a vaccine.
The goal of a vaccine program for COVID-19 is not necessarily to get to COVID-0, but it's to tame this virus, to defang it, to remove its ability to cause serious disease, hospitalization, and death.
It helps to look at the different outcomes of an exposure to COVID-19 like this. The best case scenario is you don't get sick at all. The worst case is death. In between, there's being hospitalized, severe to moderate symptoms, or having no symptoms at all. In the absolute best circumstances, vaccines give you protection all the way to here. But realistically, that isn't the main objective of COVID-19 vaccines. The real purpose is to give your body enough protection to cover these possibilities. So if you do get an infection, it feels more like a cold than something you'd be hospitalized for. And this is one thing that every one of these COVID-19 vaccines do well. In all these trials, while some people in the placebo groups were hospitalized or even died from COVID-19, not one fully vaccinated person in any of these trials was hospitalized or died from COVID-19.
One thing that I wish that Mayor would have understood was that all three vaccines have essentially 100% effectiveness in protecting from death.
The mayor of Detroit did backtrack and said he'd start taking Johnson & Johnson doses because it's still highly effective against what we care about most. Efficacy matters, but it doesn't matter the most. The question isn't which vaccine will protect you from any COVID infection, but which one will keep you alive or out of the hospital? Which one will help end the pandemic? And that's any of them.
The best vaccine right now for you is the one that you're offered.
With each shot that goes in someone's arm, we get closer to the end of this pandemic.
All right, let me just stop that video. All righty, and then, all right, so hopefully as interesting as I did, but I found it a really nice and clear explanation of this question of efficacy, which is sort of hard to wrap your head around sometimes, at least for me. One of the common questions asked is, what about protection against the variants of concern? And now we've identified several of these. This is just a small snapshot of many of the variants that have been identified. In March, 30% of all samples tested in Ontario had a common variant of concern mutation. And we know that the variants of concern are likely to result in more serious illness and higher risks of death. And certainly I think we're seeing some of that in this third wave. So you saw a little bit in that video. We think that, Pfizer and Moderna are likely still protective against at least B117. The Moderna vaccine may be slightly less effective against the variant B1351. However, it still lowers the risk of serious illness. And then P2, we still have not a ton of data on. So I think part of it is that, this question is a commonly asked one, and it's a hard one to answer because I think that the data is just changing so quickly and evolving so quickly. I think it doesn't change the fact that all of these vaccines sort of lower the risk of hospitalizations, severe illness, and death. What this means in terms of long-term immunity, durability, the need for booster vaccines, I think is still all up for debate and still under question. And that's another one of the commonly asked questions is, will we need a booster vaccine? I think it is certainly possible, but as of right now, there have been no recommendations for booster vaccines. And I think that will continue to evolve. One of the other commonly asked questions is, how soon am I protected after I've been vaccinated? So it depends on the vaccine you get, but generally speaking, most of these vaccines, as we talked about, are 2 doses somewhere between 3 to 4 weeks apart. Full protection begins about 1 to 2 weeks after the second dose. However, you're partially protected within 1 to 2 weeks of the first dose. Duration and frequency of vaccination, as I just mentioned, are to be determined a little bit. One of the questions that's also asked is, what about this duration extension to 16 weeks? I'll talk more about that in a little bit. Of course, a commonly asked question is, are these vaccines safe? And I apologize that this table is a little bit small, but I think it's a helpful one in kind of comparing these 4 vaccines across the board. Although, again, remembering that these were not studied head-to-head in any particular trial. All the vaccines have essentially what you would expect in terms of side effects for any vaccine, right? So the common stuff, more than 1 in 10 people will have what you'd expect, right? So it hurts a little bit at my injection site, maybe a little bit tired, maybe a little bit of headache, muscle aches, maybe some chills and fever. I can certainly attest to after my second shot of the Pfizer vaccine, I definitely had a fever for about 24 hours, but then it was short-lived, self-resolving, and then it was done. Less than 1 in 10 people may have some redness at the injection site. They might have some nausea or, vomiting and diarrhea with the AstraZeneca. But again, that's still relatively uncommon, self-resolving and short-lived. And then there's the rarer risk of allergy to the injections themselves. Again, less than 1 in 100 people have kind of these more infectious more allergic related symptoms or kind of more pronounced feeling generally unwell. Or like, for example, lymphadenopathy has been described, but again, relatively uncommon. And then very rare side effects include, again, this is not different from most other viral vaccines. So certainly Pfizer's or Moderna's vaccines are not unique in this aspect, where less than 1 in 1,000 people have, for example, acute peripheral facial paralysis or a palsy of some kind, which has been described with both mRNA vaccines, but also described with many other viral vaccines. And there was just recently a paper that came out, I think last week, that suggested that the rates are not dissimilar from other viral vaccines. So kind of just to summarize, most likely people will have the typical post-vaccine reactions: headaches, muscle aches, fatigue, maybe chills and fever or pain at the injection site, short-lived, self-resolving, usually 24 to 48 hours. I'm nowhere near that specific, so apologies for the typo. One of the more concerning side effects that's come out and that's received a lot of media over the last little bit, so I think it deserves kind of its own few slides, is the question of blood clots, which were initially described with the AstraZeneca vaccine, but now have also been described with the Johnson & Johnson vaccine. So essentially it's like these viral vector vaccines, the non-mRNA ones, where this has been described. You might also hear the term VIPIT, or vaccine-induced prothrombotic thrombocytopenia. I'm hearing more frequently VIT now, vaccine-induced thrombotic thrombocytopenia. This phenomenon typically occurs 4 to 30 days following a vaccine and involves kind of exactly what it sounds like, a thrombocytopenia, and then kind of, almost confusingly, a prothrombotic phenomenon, typically also including rare sites, so cerebral vein sinus thromboses or splanchnic thromboses, but can also include kind of the more typical clot sites like a DVT, for example. It's still quite rare, so 1 in 50 to 100,000 people. And people often ask, well, I have a history of DVT after a long plane ride in the past, or, I had cancer treatment 5 years ago and I had a DVT or a PE. What does that mean in terms of my ability to get one of these viral vector vaccines? And it's generally thought that the mechanism of thrombosis is quite different in those phenomena. So that kind of clot is not necessarily a contraindication to getting one of these vaccines. However, the mechanism does seem to be similar to that in heparin-induced thrombocytopenia. So for anyone who's had heparin-induced thrombocytopenia, which is kind of like having a heparin allergy, for heparin-induced thrombocytopenia, it's not recommended right now to get one of these vaccines. The data continues to evolve and the recommendations continue to evolve. And so, places where you can find information include Thrombosis Canada, the National Advisory Committee on Immunization, and Health Canada. This is an image that I've seen kind of circulating on Twitter and on the internet. And I've actually found it quite useful in terms of thinking through, risk for yourself, but also thinking through risk for counseling other people. While there is a risk of clots with the AstraZeneca vaccine or with the other viral vector vaccines, and I think, there's certainly concern around the severity of those types of clot, particularly the cerebral ones, which can be quite severe. It's also important to remember that there are many things that we do that have risks of blood clots, and there are certain risks that, for example, we are often willing to take on with informed and shared decision making. And then I think probably one of the most important things to remember is that COVID infection itself causes a risk of clots. So whereas with VIT, we're looking at 1 in 50 to 100,000 patients who might develop this, the risk of thrombosis in a patient with COVID-19 who's hospitalized and in the ICU is 15 to 20%. For those who are hospitalized and on the medical ward, the risk is 5 to 10% and is about less than 1% in people who are kind of out and about with mild or asymptomatic COVID-19. So, to summarize that, it's more likely that an unvaccinated patient will contract COVID and develop thrombosis than develop VIT after the vaccine. So I think that needs to be thought about when thinking through the risks and benefits of taking a vaccine. And I think that this kind of, informed decision-making really needs to happen. People kind of need to have all the info to do that. I had promised to talk about the extended duration. So people often ask, is it effective if we wait 16 weeks to receive a second dose? So NACI has recommended increasing the length of time for essentially all the vaccines that we have available. In part because if you think back to what I was saying earlier on about this idea that, vaccination is essentially both an individual and a community level phenomenon, the idea is that particularly in the context of limited vaccine availability, this mechanism for delivery essentially will increase overall protection, throughout the community, as everyone receives a first shot and partial immunity earlier. Certainly more recent data suggests that first dose can be protective for up to 2 months for the mRNA vaccines and up to 90 days for the AstraZeneca vaccine. And several modeling studies suggest that this is a reasonable approach. And so that's why it's been what's recommended right now, with the exception of people who have particular immune conditions, like being a transplant patient, for example. And that's largely driven by the fact that there are concerns about their ability to mount a sufficient immune response without that kind of early booster. Lots of questions as well about what if I'm pregnant, what if I'm planning to get pregnant, what if I'm breastfeeding, what if I'm immunocompromised. So part of the challenge is that in these studies, people who often fit into any of these categories are excluded from study participation, which is its own challenge and I think ethical concern. And then the question becomes that once this is being rolled out, can you say that it's okay for these groups to get it when they weren't involved in the initial trials up front? I can sort of, again, full disclosure, I was breastfeeding at the time when I got my vaccines. And so I think it's an important thing to remember. And the way that the guidelines evolved actually was initially, it was like a blanket statement, like, no, this should not happen. And then it was this needs to be informed decision-making with your provider. And now it's kind of broadened even further to sort of say, actually, particularly for the pregnant and breastfeeding categories, it's important to have agency and autonomy in making these decisions. And certainly there's no theoretical reason to think that it would be problematic to get vaccine in those contexts. And if anything, we know that people who are pregnant are at risk for complications if they get COVID-19 infection itself or SARS-CoV-2 infection itself. And so that's why all the more reason to strongly consider a vaccine and have that conversation with your providers. But so there are no major concerns to getting these vaccines at the present time, recognizing that they were not included in the studies. However, essentially post-production, many pregnant women and breastfeeding women have gotten vaccinated in that time, or breastfeeding and pregnant people have gotten vaccinated in that time. The question of if I'm immunocompromised, again, most immunocompromised people were not included in those studies. I would say that if you are immunocompromised, it's important to have a conversation with your provider because there may be nuances and subtleties that I don't want to kind of make a blanket statement about. But generally speaking, it is recommended for immunocompromised people to get the vaccine. But there may be important factors to consider in terms of timing and whatnot. So it's important to have that conversation with your provider. One of the other questions that comes up is people often say, well, am I taking a vaccine that could go to others? You know, I'm young, I'm healthy, there's vaccine shortages. And to that, I would say a few different things. So one is, as I've said many times, I think already, vaccination is a community phenomenon. So the more people that are protected, the lower rates in the community will be, and the less likely everybody will be to get sick. The key thing is vaccines in arms and not freezers, right? So if you're offered a vaccine, you should take the vaccine. And it's like, not just for yourself, but for everybody else. And again, because COVID transmission is largely driven by community rates. I will also just add to this piece of I'm young and healthy, do I really need this vaccine? I would just add that, you know, in my anecdotal experience, but it's certainly not just my experience, in this third wave, we are seeing far more younger people sick, and including, you know, intensive care level sick in the hospital system. I think that's largely driven by a variety of factors, including transmission, and where transmission is happening largely in workplaces where there aren't adequate protections, and you know, people have to go to work when they're sick because there's no paid sick days and all of these other factors. So it's very much, you know, we're seeing it in younger populations, and I think also driven by the fact that vaccination has been so aggressive in long-term care facilities, as is appropriate. We're seeing that demographic shift in this third wave. But all that to say that there are many people who have gotten quite ill with COVID who are otherwise young and healthy. So, you know, if this is a concern for anyone, that am I taking a vaccine that could go to others, I would say that is not something that is for you at the individual level to worry about. You know, if you're offered a vaccine, you should take the vaccine. One of the other questions that's asked is, you know, do I still need to wear a mask? Will I still need to socially distance? Can I travel? The answer to that is actually still yes. Again, because community rates are so high, it's still important to wear masks and appropriately socially distance and perform hand hygiene to prevent the transmission of COVID-19. Increasingly, we are finding data to support that not only do these vaccines work in terms of decreasing your likelihood of getting sick enough to require hospitalization and to prevent death, but perhaps they're also efficacious in terms of preventing asymptomatic disease and transmission. But as of right now, we still need to do all of these things. The travel question is an interesting one. I think we're starting to see things around, you know, vaccine passports and all of this, and I think that's a much bigger policy discussion than kind of what, than probably what we can talk about right now. But I would sort of say that, you know, to me, the way that I'm viewing it, for example, as a fully vaccinated person, I am not traveling. I still think of myself as potentially at risk as we continue to learn more about these new variants, and as we continue to learn more about, you know, overall community transmission and rates being so high right now. I think I would still travel with considerable caution if that's something that needs to happen. And I would view it as a, like, is it something that's essential, or is it something that perhaps can be deferred? The question of asymptomatic transition in the context of vaccination is also one that comes up. You know, if I'm vaccinated and my family isn't, can I spread the virus to them? So again, growing evidence that fully vaccinated people are less likely to have asymptomatic infection and therefore less likely to transmit, typically after at least, you know, 10 to 14 days of that initial vaccine. But it's not necessarily zero. So I would still, you know, use whatever precautions you're using with your loved ones, and mostly that means, I think, protecting yourself outside, right? Because everyone has sort of decided on something different within their families, but, you know, for example, I'm not isolating from my family despite going to work, right? Then the question of, would I show symptoms? So it lowers your risk of severe disease and likely lowers your risk of asymptomatic infection, but that doesn't mean that, you know, you're we often hear that, well, I was feeling completely fine, so I thought it was okay to go to my cousin's house. And so, you know, feeling completely fine is not necessarily the same as not having COVID. And you know, there's a lot of reasons for that. One, asymptomatic infection, but also pre-symptomatic infection, right? So the idea that, you know, you don't have symptoms yet, but maybe you would 3 days from now, but you were still able to transmit during that visit, for example. People also ask, well, what if I've already had COVID? Do I still need the vaccine? So NACI recommends that a complete series with a COVID vaccine, any vaccine, should be offered to people without contraindications to the vaccine who have already had COVID. The duration of immunity after COVID is after COVID infection is unclear. Reinfection has been reported. We've certainly seen reinfection, usually after 3 months. It's rare for people to get reinfected within that first 3-month period, at least based on what we know right now. So it is certainly recommended that people get vaccinated, even if they've already had COVID. The one kind of nuance to that is typically it's recommended that people are better from their COVID infection, partly because if they're still sick from their, like actively sick from their COVID, and then you vaccinate them and then they have a fever, then it's unclear as to what's going on. So it's typically recommended that they're feeling better. And for many people, that's usually by the time they're out of isolation. So kind of that 10-day mark. And again, recognizing population level versus individual level consideration. So in some places where vaccines are really, really scarce, they're specifically saying, if you've already had COVID-19, we want you to wait 3 months before getting your vaccine so we can vaccinate all these other people. In Canada, that's not necessarily what's being said right now. So if you have a patient, for example, who's already had COVID, if they're better from their COVID, they can get vaccinated, as long as there's no other contraindications. So that's everything that I had kind of formally prepared. And I think I've addressed to the best of my ability most of the questions that were in that kind of key questions document, but I'm happy to field any other questions that might have come up either through the chat or or in person.
Thanks so much, Dr. Sharma. Can everyone hear me?
I can, yeah.
Yes. Okay, wonderful. That was really, really great. You answered pretty much all the questions that we had sort of collated together prior to this presentation. There's only one that I think still is outstanding, and that is just, kind of your opinion on how we can address vaccine deliberation. Is it just, providing information like you have provided for us today, or kind of what your thoughts are about this vaccine hesitancy versus, how you've phrased it so nicely as vaccine deliberation?
Yeah, so, I think the question of vaccine hesitancy or vaccine deliberation, this is like a pre-COVID phenomenon, right? So it's been something that people have been thinking about for a while. What seems to have the most impact is hearing about vaccines and having your questions answered from someone you trust. Right. And so part of why, for example, like we're doing this session today, and I don't necessarily expect any of you to trust me because you don't know me, and that's totally fine. But, part of it is trying to have, the division of IDs, like we're trying to take the show on the road a little bit and sort of, if there's any small groups that want to, if there's any small groups that, for example, like a particular floor or a particular unit where there's low vaccine uptake, actually having smaller group kind of in-person sessions where you can actually talk to someone and have your concerns addressed, those have been helpful. I think part of why, for me, it's really sad that at the kind of broader provincial level, primary care providers were not necessarily involved in the vaccine rollout is because actually, people have longstanding relationships with their primary care providers, and that's actually kind of like an ideal point of contact, right? To hear about vaccines from someone you trust. So I think that that's a big part of it. And then I think, I think I kind of alluded to this a little bit, the particular concerns around vaccines are going to be different in different groups who have different histories and experiences with the healthcare system. So I think specifically hearing about it in ways that you can trust and ways that are culturally appropriate and relevant. I'm thinking specifically about my colleague, Lisa Richardson, who was traveling, and Suzanne Schuch, who were traveling with Orange to deliver vaccines in the north, and some of the culturally safe vaccine information that was being provided in those contexts. And so I think for me, it's a lot of it is it kind of has to happen on the small scale and actually hearing about it from people that and creating safe environments for people to talk about that, I think.
Mm-hmm. Yeah, no, that sounds great. Another question I see here is related to booster shots. Especially us in healthcare, many of us, not all of us, but many of us were able to get the full series before we realized that we needed to space things out in order to sort of have a better control of the population in terms of infections. And so there's a question about whether or not healthcare workers and other people who kind of were fully vaccinated early will need a booster.
Well, and I think that's, it's too early to say. I think maybe, but I think we just don't know yet. And certainly as of right now, there's no recommendations for a booster shot at present.
And just to follow up on that, I see a question about how long the efficacy will last of a full vaccination series. We kind of don't know, or do you have any thoughts about that?
I don't know yet. I think it's not been long enough yet.
Fair.
Yeah.
People are worried about their children. There's lots of controversy about schools and daycares and stuff being open or closed. What are your thoughts in terms of the vaccine, like the likelihood of children having access to the vaccine? I do see in your presentation you said vaccines have been approved for 16 or 18 and
Yeah.
above in many cases, but how about below that?
I think there are some studies happening right now in as low as 12. So that's sort of being studied. We do see that, while children thankfully don't seem to get as sick with the virus, it's not to say that they can't transmit it, right? And so I think, if we have the capacity to champion for people to, for example, lobbying our MPs to say, like, why are ECEs and teachers not being vaccinated, like this needs to happen, I think is one thing. The other thing is just driving down community transmission, right? The less community transmission there is, the less likely those children are to get exposed, and then the less likely they are to transmit, and like the less likely this whole production is to like continue, right? So I think that to me is kind of like the key to
Right.
all of
And
this.
it goes back to what you were saying, like if you get offered a vaccine, go ahead and take it because it helps you and the community.
Totally.
Okay, thank you. Now, earlier in the presentation, you did talk a little bit about the delay, the 16-week delay, which isn't what we saw in the trials. And so there's a question here about in that time zone, like after the first shot, you had said, some studies show protection for 2 months or 3 months. Should people feel like they're kind of back to square one after that 2 months or 3 months after the first shot while they're waiting for their second?
No, I mean, I think people should essentially, there's two parts to that. Like, I think one is people should essentially follow the recommendations of what's being recommended to us right now. So if that's what you have access to, which is like you get it now and then the next one in 16 weeks, like that's what I would do, right? Because that's what's being offered to us. And I think it's, it's not based on nothing. Like it's based on some data to suggest that, the data we have so far suggests that at least the protection is until at that point, and the modeling data suggests that we can probably wait 16 weeks. So that's, it is what it is in this kind of vaccine scarce environment. So I would say that's, do what's recommended. I wouldn't, and as of right now, it's not being recommended to kind of restart a series or anything like that, right? So people actually ask, like, should I go to the US and get my second shot? Like, to me, the risk of getting on a plane and going to the US to get your second shot is like far higher than just like sitting at home and waiting for your other shot. And that, I think, is the second point, is like really trying to minimize risk as much as we can. And I'm recognizing that that's also like not everyone is able to minimize their risk because they're an essential worker going into a potentially unsafe workspace, right? And so like I'm mindful that as I say that, there needs to be essentially advocacy happening on like, yes, the individual pieces that we can control, and like not going over to our cousin's house and, not having indoor gatherings, and sure, like we should be doing that. But we also, I think, need to be, essentially lobbying our governments to protect people in workplaces, right?
Right. Thank you. And so I have one final question now, unless any more come through. And this is about getting reinfected. So if you get a natural COVID infection, do you have any thoughts on how likely you are, like the timeline, whether or not you can get reinfected with a variant, or any thoughts on that sort of topic?
Yeah, so I have no like actual numbers, like, this is the likelihood of getting infected, because that likelihood is driven by so many things, including like how much COVID is there in the community. Like if you've managed to vaccinate everybody and now there's like way less COVID in the community, you're not likely to get infected again, right? And if you are someone who is in a high risk scenario every day versus, you are able to be at home and work from home and not be exposed, then that's, your likelihood varies based on not so much inherent biological factors as like these broader external factors. But we know that you can get reinfected after natural COVID infection. The data suggests that it's rare to have that happen within the first 3 months. So, probably natural immunity lasts around that 3-month mark. That's partly why we still recommend that people get vaccinated, because it's almost like your vaccine is your booster for the infection that you had, right? So it's kind of giving you protective levels of antibody. So I think the key thing is that, until this pandemic is kind of at the broader societal level, like brought down to ideally zero, but, just less, I think we have to, vaccines are just one part of it, and there's all these other pieces that have to happen.
And so would you recommend that even people who've been fully vaccinated, or not necessarily recommend, but what are your thoughts on people who are fully vaccinated continuing to get regular COVID tests if they work in healthcare or they feel like they're exposed or things like that?
Well, I think the question of, whether or not they should get COVID tests is largely driven by, I would say all the regular reasons to get a COVID test. So if you are, in a workplace and there's a COVID outbreak, just because you're vaccinated doesn't mean you shouldn't get tested, because you could still get infected, right? So whatever the recommendations are from your occupational health body around that is what I would recommend, because there's going to be nuances there too. So for example, if you are fully vaccinated and you were in a room for 5 minutes with someone who, eventually tested positive for COVID-19 and their mask was off for 30 seconds while you were, looking in their nose or something, that risk is probably different than, you're fully vaccinated and your husband tests positive for COVID, who you live with, right? So those are probably those are different scenarios in terms of risk of exposure and risk of disease acquisition. And so it's kind of hard to sort of give a hard and fast rule, which is, I think, why I would sort of say that, in both of those circumstances, you're going to be recommended something by public health or by your occupational health body. And I think while you are individually more safe, you still kind of have to probably do the testing and kind of follow the regular rules. And again, I guess the other piece of that is, if you've been fully vaccinated and you have the sniffles now, and your workplace's recommendation, as most workplaces right now for us in healthcare, it's like, if you have the sniffles, you got to go get a COVID test. You got to go get a COVID test, right?
Fair enough.
Yeah.
Okay, great. I don't see any more questions, and I've just reviewed our list of questions that were sent in, and we've addressed all of them, which is amazing. Thank you so much.
No problem.
So I think Tiffany was going to add some information about our vaccine rate here at Providence.
Hi, everybody. So on behalf of all of us at Providence, I want to thank Dr. Sharma and Dr. Johnson for their presentation today and answering all the questions that we had about COVID-19 and vaccines. I also want to thank everybody that's online, all the staff members, physicians, and learners who submitted their questions beforehand and who asked questions during the session. So we are planning in the future to have more opportunities for staff to ask questions and to have experts across Unity provide the answers. So please stay tuned for future announcements in our twice a week and corporate communications. So I did want to update everybody. Providence is continuing to run our vaccine clinic on Thursdays. And to date, we have vaccinated a total of 1,486 people. And that includes people like staff, inpatients, houses residents, outpatients, adult day program clients, and essential care partners. So please check our COVID-19 microsite for latest information on eligibility and clinic bookings. And I also want to let staff know that if you're interested to be put on the staff residual list, you can email YY Vaccine Clinic so that we can reach out to you on Thursdays. So that happens to be today. If we have any leftover vaccines due to no-shows or cancellations. So
Tiffany, can I ask one more question?
Go ahead.
To you about this session has been recorded. I've just had some questions about how people can view it, or if they can view it.
Yes, it is recorded. So we will send out communication later today about how to access that recording. Thank you. But yeah, that's it from me. I want to thank everybody for joining, and we'll talk soon. Thank you, Dr. Johnson and Dr. Malika Sharma.
Thanks so much, everyone.